welcome everyone. It's been a while since I've been on a webinar, but so just in case anybody doesn't know who I am, I'm Charlotte. I'm the Patient Advocacy Manager here at Leukaemia Care, and I will be chairing today's webinar, joined by two very eminent doctors who are going to talk us through their views on choosing between treatments of CLL. Just a couple of housekeeping points before we begin. If you'd like to ask a question, please do so at any point. You can ask a question that everyone can see, or you can ask a question just to the panelists in private. And you can do this using the chat function, which is the little speech bubble, usually at the bottom of your screen. Like I said, please do ask them sort of throughout, and there'll be a period of time at the end where we then sort of discuss your questions. So the topic of today's webinar is to discuss the different types of treatment we have in CLL, specifically looking at the difference between those that are intended to be continuous versus those that are fixed duration treatments, and whether that's still the case is something we can talk about later, but that is the idea. And I've seen this talked about in numerous clinical conferences, so we thought we'd bring this to you as patients today and see what you guys think. So I believe first up we have Renata. Renata, would you introduce yourself and then head straight into your introductory talk?
Thank you, Charlotte. Hello, everyone. My name is Renata Walewska. I'm a hematology consultant in Bournemouth. So I practice in South Coast. So today I will be taking you through fixed duration therapies and just give you a little bit of a historical context. So first, I would like to take you through the evolution of CLL treatment. So the CLL treatment really started late 1940s. Professor Galton introduced chlorambucil, which is the alkylating agent, which is very close chemically to the nerve gas, which was used in the First World War. And chlorambucil initially, back in 1950s, was actually used as a maintenance type of treatment. So people used to be on it for months and years. There were times when prednisolone was added. As you can see in the graph, there was nothing really until 1990s when fludarabine first was introduced. And fludarabine was combined with fludarabine cyclophosphamide because fludarabine was quite toxic. So that here became a fixed duration treatment. In late 1990s, we had a CAMPA for TP53 aberrant CLLs. Then FCR in the early 2000s, and obviously in some cases we still do use it. There was ofatumumab, so there's a monoclonal antibody, which been and gone really. And really since 2014, so this is truly a landmark year for us as a hematologist, because this is first time we've seen Bruton tyrosine kinase inhibitor introduced to hematology clinic. And after that, as you can see, there was an avalanche of new treatments, idelalisib, rituximab, which is another B-cell inhibitor, venetoclax, and combination of these. So this is the old type of treatment, so chemotherapy based and chemoimmunotherapy. So that's kind of almost finished in 2000s. And then since 2014, it's a new. But what is interesting that obviously, as I mentioned, chlorambucil initially was given as a maintenance treatment. Then we moved to fixed duration. Then when ibrutinib first came on a scene, it still is being given as a maintenance type of treatment. But with venetoclax rituximab, it's backed to the fixed. So as you can see, we've done a full circle. This is very busy slide, and I'm sorry about this, but this is really just to show you how long does it take to develop the new treatment. So if you remember, it was 2014, we got BCR inhibitors in clinic, and actually ibrutinib, so Colonel Bruton, first described A-gamma globulinemia, so inherited condition in boys. So it was back in 1952. And as you can see, it took a while till 1990. So the gene was characterized, first synthesis of ibrutinib predecessor, PCI 327-765, was in early 2000. Then obviously first clinical trials, and it led in 2014 to approval. And then you can have a look at the idelalisib, which is also works kind of similar to ibrutinib, but it works slightly different, and sometimes we do use it as an alternative. Had a similar sort of run in parallel to ibrutinib, and here venetoclax. And again, venetoclax was first sort of the idea of blocking BCL2 came about in 1980s. And here you've got this red dot, which I put it here, where there was clinical hold because there were some deaths described in phase 1 studies. So that put slightly the venetoclax on hold. And that's why, in a way, venetoclax, although as you can see, it's kind of gone in parallel with ibrutinib, got first authorization 2-3 years later after ibrutinib. And this is a very old slide, but just basically to show you how long we've come. So patients who were diagnosed with CLL between 1980s and 1994. So if you remember from my historical data, this was basically time of chlorambucil only, maybe chlorambucil prednisolone. This is what happened to the patient. So if you look at, I'll have quite a lot of survival graphs, so I'm sorry about this, but basically the survival graphs means that if I had a straight line, this is obviously a utopia type of graph when essentially no one dies. With every step in that line, obviously somebody dies from the population we're looking at. And you can see from chlorambucil era, the patient didn't do very well. And by 10-year follow-up, we barely have got 20% patients still alive. The other graph just above it, so this is 1995-2004. So this is the time when we've got FC and then FCR, so chemoimmunotherapy. As you can see, that got better. And this is a breakdown which shows inclusion of the novel therapy, the inhibitors. And as you can see, that survival graphs gets better and better. Of course, we're never going to have a flat line because people tend to get unwell for other reasons. But at least I think for good prognosis CLL, for CLL or in intermediate risks, we're getting very close to normal expectancy. So when we think about treatment consideration, obviously the most obvious one is a first line versus relapsed. Then there is a fit versus less fit. So we've got patients who are very fit, go. So this is the old description stemmed from German group, where they decided to have a very fit patients, go, very unfit patients, no go, and somewhere in the middle, slow go. Luckily, with chemotherapy not being first line of treatment anymore, and we've got inhibitors, because it works so well, and I show you the data in frail patients. So if it works in a frail patients, why not it does not work in a fit patients? And I'm pleased to say that we've got more data just to show that actually that split between fit and less fit doesn't really matter. Well, it does, which I'll show you in my last slide, but not to such a degree as it used to. And this is a clinical guideline which Piers and I prepared for British Society of Hematology. So that was updated from 2018. And what comes next will be, in a way, reflection what we put in that guideline. So the new paradigm which has been introduced with the new treatment, especially with a fixed duration, is MRD, which stands for minimal residual disease. So I'll just take you through that. So 10 to 0. So 10 to 0 is really a level when we know the patient has got detectable disease. So we can see a lymph nodes. We do full blood count and the white cell count is slightly raised. So this is where that patients before treatment is. And obviously we follow the strict IWCLL criteria. So we don't just because somebody's white cell count slightly gone up, that's not enough to start treatment. So we usually follow IWCLL criteria, where there is obviously patient symptoms, abnormal full blood count, and maybe lymphadenopathy, which would guide us towards treatment. And so if we say we'll take this line, the top line, and we give this patient chlorambucil. So of course, with chlorambucil, we see some reduction in white cell count. We see some reduction in peripheral blood, but we can still see that. So if I look at down microscope, I can still see those CLLs. So this is remission, and obviously those patients will relapse few months, maybe some of them few years later. But if we can reduce the level of CLL to 10 to minus 5 or even lower, this is where it's MRD, what we call undetectable range. We can almost hazard a cure. Obviously, cure is overrated statement. But on the other hand, if this disease is so low that it takes years to come back, this is really deep remission. And this is all about how deep remission we can get from the treatment. So MRD, essentially with the new type of treatment, is the holy grail. So let's look at the studies. So the first study, which truly introduced MRD as something which can be quite easily attainable, even in patients who are relapsed, was Murano study. So this was a randomized study with 389 patients. As you can see, was 1-to-1 randomization between venetoclax rituximab, so the new type of treatment, versus chemoimmunotherapy, which was in this case bendamustine rituximab. And this is the most up-to-date graph. So as I mentioned to you, the flatter the line, the better the treatment. So each step in that line, so each drop down means the patient, so here time to next treatment. So that means that each step equals a patient who requires another treatment following this original treatment. So in blue, it's venetoclax rituximab. And as you can see, 50% achieved time to next treatment at 57.8 months. So we're talking more than 5 years, and these are relapsed patients. So it took more than 5 years before we started considering in 50% of these patients another line of therapy. So this truly changed a paradigm how we treat the patients, because in previous studies, when we gave those patients chemotherapy, that time was only about 12, it depends which study you look at, but it was between 6 and 12 months. And here for bendamustine rituximab, it's 23.9 months. So that's obviously, that's what we have expected it. And also what it showed that it's been active in IGHV mutated patients. So it does have some activity in unmutated as well. And the TP53 patients can respond to that as well. And this was published in an editorial. So it was quite interesting because obviously, you know, as I said, it was that these are patients who are already relapsed. So they are far more difficult to treat. So actually what happened, you know, it's nice to see survival curves, but actually what happens to those patients? So it is interesting that basically 38.6% of these patients still has got undetected MRD, which was quite, well, it still is quite astounding. Then another 30 odd patients, well, they have detectable MRD, but they don't have a progressive disease. So they don't need to be treated. And then we've got 27.7 patients, which they do need treatment. So let's switch to the front line. So obviously the study which I showed you, that was in relapse setting. And because it was so amazing in relapse setting, obviously we started using similar combination in frontline. And the first study in frontline was in frail patients. So that's CLL14, that was a big German study group. So instead of venetoclax rituximab, we've got here venetoclax obinutuzumab, which is a better version of the same antibody. So looking at the antibody directed at the same molecule, but because it's glycosylated, we know this antibody is more effective. And we've got the standard therapy was chlorambucil obinutuzumab. And again, you've got the survival curve, and you can see on that survival curve that patients with blue, with venetoclax obinutuzumab do much better. So this is cumulative survival, and chlorambucil obinutuzumab, as you can see, they kind of do as we expected them before. So 5-year progression-free survival rate, we've got only 27% of patients who have not progressed. And this is against MRD status. So MRD became quite an important factor after introducing venetoclax. So as I showed you on the previous slide, the deeper MRD, so if we can't detect the CLL at all using current standards, then the cumulative survival is better. So you've got here in green, so this is less to 10 to minus 5. As you can see, it's overlapping with the blue, which is between 10 to minus 6 and, sorry, can't see, 10 to minus 6 and 10 to minus 5, versus the red one. So the red one is detectable, so 10 to minus 4. 10 to minus 4 is still quite a good outcome, but as you can see, the patients who've got less disease on board do better. And then Dr. Al-Sawaf, who presented the CLL14 data at the last EHA, took this even further. So they were looking at the levels to 10 to minus 6. So just dividing into 10 to minus 4 and 10 to minus 6, and showing that patients who have got really deep undetectable MRD do even better. So it is worth chasing that MRD. Currently, we don't do MRDs as a standard of care. We don't assess MRD, but of course, future, this is where all the clinical trials would be aiming at, trying to assess the disease according to MRD and maybe adjusting the patient, the treatment to those patients. So we can get all of the patients into this line. So let's look what's happened with frontline and fit patients, because the study I just showed you, it's supposed to be only for frail patients. And this is where we were when we were asking for NICE approval, because all the data was there for frail patients. But what about fit patients? You know, it's just, it felt so not right that we, on one hand, we can give that fantastic treatment of venetoclax obinutuzumab in frontline, and yet if there is a young fit patient, there would be only chemotherapy there. Yes, to some of the patients chemotherapy might be the right choice, but in vast majority we would like to give them novel therapy. And here the CLL13 comes along and essentially proven what NICE very generously gave us as a conditional approval for a fit patient, venetoclax obinutuzumab. So this is a very, very large, ambitious study. As you can see, 920 patients in total, and there are 4 arms. So as you can see, the first arm is a chemoimmunotherapy. So it's a FCR or bendamustine rituximab. Depends, in Germany, clinicians cannot give FCR if patients are over 65, so hence BR. Then rituximab venetoclax. So do you remember the combination which was a winner in Murano? So it's been used here as a front line. Then GV, so that's the same as a VO, so venetoclax obinutuzumab. And here we've got a triplet of venetoclax, obinutuzumab, and ibrutinib. And we've got some initial data. And I think what it is interesting that it's just kind of going in pairs. So if we look at how efficient this combination is, so chemoimmunotherapy is kind of comparable to rituximab venetoclax, and then venetoclax obinutuzumab is comparable to a triplet, which was a bit of a surprise, but I think it's quite reassuring. We don't need to put all the new agents we've got available in first-line treatment. And this is, again, progression-free survival at 3 years. So this study is it's still early on, and we're going to have a final readout in January 2023. But as you can see, the red one is venetoclax obinutuzumab. So it's those patients are doing really well. And the black one is a triplet. And at the moment, there is no statistical difference between them two. So basically what it means, venetoclax obinutuzumab is really good combination to give it first line. When we look at chemoimmunotherapy, so FCR or bendamustine rituximab, so this is a green line. As you can see, those patients don't do very well and relapse pretty quickly. So as I told you, each step down, it's each patient which required therapy. And then in blue overlaid, sorry, the blue is the chemoimmunotherapy and the green is venetoclax rituximab. So I must say I was very surprised when I saw this data that venetoclax rituximab, the combination which truly revolutionized the way we treat relapse patients, actually when compared to venetoclax obinutuzumab, it's not as good as venetoclax obinutuzumab. So what do we do if patient relapse? So whenever you decide on treatment for a patient, I always think what I'm going to do next anyway. So, and kind of trying to use the options. What can I do in a second line and I can't do it now, and vice versa, to make sure that I use all options which are open to the patient. And this is a table which we put in the guidelines just to guide people what you do next. And I think bottom line, there is no right or wrong answer. There are no really good clinical trials to compare what the sequencing is, and sequencing, it's became true art. What do you do after? Bottom line is, it doesn't matter what you do after, because we've got such a good drugs at the moment, and we can use one after the other. And also we can use venetoclax because it's a fixed duration. We can have a second bite at the cherry, so we can use it second time round. And which one is better? So obviously I'm not going to say too much about maintenance, because obviously peers will expand on this much more. But I think with a fixed duration, it doesn't matter really which one we choose. I mean, I've just shown you how good venetoclax obinutuzumab is in frontline, how good venetoclax rituximab is in a second line. I think the beauty of that is that the patient can concentrate on treatment for a limited period of time. So with Vena, 2 years, with Veno, 1 year. And I think I find at least that patients are probably better compliant, because they know they just need to put everything on hold and just concentrate on treatment. I think the other important thing is we don't really, especially with frontline, we don't really need to use much of a prophylaxis. The drug interaction can be a problem with both fixed duration and maintenance. Yes, the tumor-lysis syndrome might be a problem, but with current titration, it's been in a way ironed out. But yeah, it means that especially the first week of venetoclax obinutuzumab, it's a very, very intense week. And the first month, it's quite busy as well. But really after sort of on a second cycle, it gets easier and easier. And certainly after 6th cycle, when obinutuzumab is finished, it's once every 3 months treatment. Of course, we've got adverse events, and with venetoclax obinutuzumab or venetoclax rituximab, it's usually neutropenia. But the beauty of this is you stop and the adverse event go away. So that's another advantage of not going on with the treatment for too long. So when I compare this to the patient, I mean, I'll just basically tell them, do you want sort of high intensity interval training? So it's done really intense and stop, or do you want to pill a day to keep a doctor away, like with maintenance? So when I'm thinking about what to put people on, so of course these are things which I picked up from guidance. So I've always checked TP53 aberration, because we at the moment it appears that maintenance type of treatment for patients with high risk disease, those ones we do have a TP53 abnormality, do better on maintenance type of treatment. It's useful to know whether they've got mutated IgVH gene, because patients with mutated IgVH genes appear to do much better on fixed duration treatment, venetoclax or obinutuzumab. And then, so this is obviously the the disease decisions. So CLL characteristics. Next, I'll go to, well, what the patient wants. Are they happy with this intense first month of treatment, and then things will ease off, or they'd rather be just treated at home and not much happens? I've got to say, my last patient in clinic, for instance, he would do well on acalabrutinib, on maintenance type of treatment. But my slight concern is he's got white cell count of already 600. If I give him acalabrutinib, white cell count will probably double. So obviously I'm slightly bit worried what will happen then. Now, the strokes are vanishingly rare in CLL, even in high counters, but of course they can happen. And I think, this is something which obviously we need to discuss with the patient, give them all information, and they need to come back and tell me what would they prefer. And of course, if we go to maintenance and the patient doesn't mind taking a pill a day because they've already having another 3-4 pills to take a day anyway, the compliance wouldn't be an issue. I added patient age here, not because how old those patients are, but how young they are. And if I've got someone who is in their 30s, 40s, and they will need to be on acalabrutinib for 10 years, it just puts things in a perspective. If I can achieve the same progression-free survival, same outcomes with the fixed and maintenance, I think the fixed duration, especially in young patients, makes sense. Then, of course, patient comorbidities. So, of course, the cardiac problems, high blood pressure, and somebody on acalabrutinib is very important to monitor and control it. And other medications. So there will be, it's always good to go through all the medications, because there are some legacy drugs which patient doesn't even remember why they're on it. The classic one is omeprazole. Almost everyone over age of 60 is on omeprazole. So in my clinic, although I'm not the one prescribed omeprazole, but I tend to take most patients off omeprazole anyway. This is just an example. And the other thing is CLL-associated autoimmune complications, because they can be quite significant. And if it's difficult to control those autoimmune complications, and those, for instance, autoimmune hemolytic anemia can be driven by a clone, by a CLL clone. So it makes sense to offer those patients treatments which will achieve undetectable MRD, because then that driving clone can be effectively removed. So benefits of fixed duration, so just really rattle through that. So obviously undetectable MRD, so that means longer progression-free survival, longer overall survival. As I mentioned, easier to control autoimmune complications. Again, fixed duration means that patients will be probably more compliant. And we can reuse that treatment. As long as patients don't relapse during the fixed duration or soon after, we can use as an extra line of therapy. But I think bottom line is we've got absolute plethora of choice, and there are all non-chemo options. Of course, there is chemo still on the table, but I've got to say, over the last 2-3 years, I have not given any chemotherapy to CLL patient. The last one I gave was on a clinical trial, so I didn't have much choice. And what is important, it's all driven by patient's choice. So bottom line is, there is no right or wrong answer, and whatever fits with your life and with your makeup and other treatment, I think that's the right treatment. The other thing, obviously, the longer you carry on treatment, the longer you've got problems with adverse events. If you don't have a drug on board, you don't have adverse event. It's very rare to have an adverse event which is persistent despite the drug being finished. So thank you very much for your attention, and I will stop here.
Thank you, Renata, for a very good introduction. You had me on fixed durations until you likened them to exercise, and then I sort of went off them slightly because I'm not much of an exerciser personally, but genuinely plenty of effective fixed duration options, which is really good to see. Hopefully Piers will now bring us into some sort of longer duration treatments, and then we can talk about whether there is a true choice here or not. So Piers, please.
Is that sharing?
It is, but we're not seeing it full screen at present.
Oh, my computer's being very odd. So let me just see what's going on here. Excuse me a moment. Stop. Okay. You are about to see it in full screen. So you see it in full screen now?
Yes, perfect. Thank you.
Great. Okay. Thanks, Renata. Thanks to Leukaemia Care for asking me to come and talk. That's just me. And I'm based in London. This is not a debate. This is a discussion about things. And this conundrum seems to have come up in the last few years, whether we should be talking about fixed treatment duration or continuous treatment. And it's a slightly artificial discussion because, as Renata has just explained, some treatments are delivered for a fixed duration because the clinical trial was designed that way. And some of them are given continuously for the same reason. And that's the evidence or data we have. Out in the real world, things sometimes don't go the same way. So patients might well be on what's called a continuous treatment and actually stop it for reasons other than the disease progressing, for instance, not being able to tolerate it anymore or just wanting to stop. And that still was a continuous treatment when it was originally conceived. And similarly, some of the drugs in these fixed duration treatments, such as venetoclax, can be given continuously. When we first used venetoclax, we didn't stop it because that was the way the trial was designed. It was only when we started giving them with antibodies that it became fixed. And really, Renata's already shown you this slide in a different way, but there are only two continuous treatments that we really might think about today anyway, and that is giving the so-called BTKI monotherapy, which would be either ibrutinib or acalabrutinib. Most patients are going on acalabrutinib these days rather than ibrutinib, or maybe venetoclax. And all the treatments we had before, which I think Renata gave a very clear illustration of how we got from chlorambucil to this point, and these later treatments are really fixed duration. So what we're really talking about is this rather than continuous or fixed. So why did these continuous therapies admit? Well, they were oral tablets, so we could give them very easily in an outpatient setting. I put there that we're more tolerable than chemoimmunotherapy or indeed Campath or anything else. But the point being was that patients, when they started to receive these, And the patients who first received these were generally those who had been through rounds of chemotherapy before, difficult to treat disease. We suddenly have these transformational medications that we could give and patients could take daily at home with really minimal side effects. And they absolutely changed the CLL arena for many, many people. Is that moving forward? Doesn't seem to want to. So to go on that, the initial trials reported this in very heavily pre-treated relapsed refractory patients. I mean, I remember them well. And we had patients who were coming up to the day unit for blood transfusions, for platelet transfusions, for injections of things like GCSF with infectious problems. And suddenly we were seeing complete normalization of blood counts, and suddenly patients didn't need their weekly blood transfusion. Their quality of life changed. I remember one of our patients who, been with us for months, almost as an inpatient, actually went back and started working again. I just don't think she could believe it. One of the points about the BTKI treatments, and that's ibrutinib, if you look hard enough, you nearly always can find a little bit of it about. We do it in a number of ways, and Renata's already touched on that. She called it minimal residual disease, which we often do. I often call it minimal residual disease. I think the term MRD is now meant to be measurable residual disease, but really the point is, can we measure it or not? So for CLL, and people who've heard me speak before have seen pictures, we only can look in the blood and bone marrow really of patients to see if they've got any disease definitely there. If you do a CT scan or another kind of scan, you can say, well, the lymph nodes don't look very enlarged, and that's great. But we don't actually know if there's any CLL around. So the only things we can look at are blood and bone marrow. We send those off to a specialized laboratory, and we use a technique called flow cytometry, and that allows us to detect a very low number of cells, either in the blood or the bone marrow. And we won't discuss now the merits of doing one over the other, except generally I will only do it on the blood, mainly because I think it's not very nice to do it on bone marrow. And I think I get the information I want from the blood. And we generally talk about, can we detect any CLL cells at 1 in 1,000, and that's called 1 × 10⁴. And as we've just seen in all that data being shown, it can be used as an endpoint in clinical trials, and it's actually very useful in traditional trials with chemoimmunotherapy. It's definitely a good endpoint. If someone's measurable residual disease undetectable, and that's this UMRD, they generally do not progress as quickly as people who've got measurable disease after chemoimmunotherapy. And it's looking the case also with venetoclax.
Oh, hi, Tash. Sorry, I've left my phone at home.
Renata just introducing us there. Generally, we don't measure that systematically outside of trials. It is done in a specialized laboratory. You need to be seen in a hospital which has got easy access to it, and that's not true for all hospitals. The point is that we get that with chemoimmunotherapy and venetoclax, but actually with ibrutinib treatments and acalabrutinib, we very rarely get it. But I can tell you that patients are very happy on long-term ibrutinib, and frankly, whether or not we can detect a little bit of CLL doesn't necessarily mean there's a problem. So it's always difficult to explain these things, but there's no doubt that continuous treatments I'm talking about are extremely effective. I know there are concerns now about the tolerability, or how well we should tolerate, and that some of the drugs, for instance, ibrutinib in the long term might be causing problems such as high blood pressure. And we need to measure that. But if a patient doesn't develop high blood pressure and doesn't have any side effects from ibrutinib, and the fact is that most patients on ibrutinib do not, why do you necessarily need to stop it? I think there's actually quite a lot of reasons why you might want to stop it, but the concept of keeping going is the idea that you have detectable disease and you give your treatment, and then you can't really detect the disease, or it's very low level. You actually keep it suppressed if you carry on treating. Whereas perhaps with a fixed duration treatment, it might start to come back. Now, this is a really simplified model, but that was really the reason why you might want to do that. And I'm not going to particularly talk about maintenance treatments, but that's the concept of maintenance, is that you carry on giving something to stop this thing happening. I'm just showing one slide from clinical trials. This is the latest report from the original RESONATE-2 study, which was actually the frontline treatment of ibrutinib with chlorambucil. And really just to say that after 8 years of average follow-up for these patients, it's still safe, it's still working very well, still half the patients who we're looking at haven't progressed, and 42% of patients continue on it at 8 years. So when you're thinking about this, it's not really either or, it's how tolerable is a treatment? As Renata says, what's the choice? As a clinician, we might be influenced by this, the minimal or the measurable residual disease status. And there is other things which I haven't really talked about today about the genetics underlying someone's CLL, which might make me choose why to recommend continuing a treatment or not. And this is the last slide, which is really, you might give someone a fixed duration therapy, and this is their disease bulk, and it goes down. And you actually might say, well, I think this patient's got very low risk disease for progression. I also can't detect it. Let's say I'm doing measurable residual disease measuring. And I might have actually got rid of the disease, and all I'm going to do is cause side effects by continuing it. Exactly the same patient, I might think, well, hang on a minute, I'm a bit more worried about the disease, and we can discuss that in a minute. And I think they might benefit from continuing. Or there might be patients where you can still find quite a lot of disease and you think it's a good idea to continue. No one size fits all. We can make some generalizations, but ultimately it's about individual. And overall, there's lots more to learn about this. So that's all I was going to say, and I'm very happy to have a discussion with questions and with Renata about the whole issue. But I don't think this is a debate in terms of that one or other thing is right, and I feel quite strongly about it. Thank you.
Great. Thank you, Piers, for that useful wrapping up on the continuous therapy side. And just to say, we've had no questions so far, but I'd be really keen to make sure in this last sort of 10-15 minutes that I ask the things that you guys are interested in hearing more about. So please do ask your questions. Otherwise, it's just me sort of guessing what you guys want to hear. Renata, I wondered whether you wanted to comment on Piers' last comment there about whether it's an either or whether we shouldn't really be comparing the two in the way that we have seen discussions go. What do you think about that?
Yeah, no, I agree absolutely with Piers that obviously there is not, it's just adjusting what fits to that particular patient. But I think what would be useful for the point of discussion for Piers to pick up from this slide one but last with the one with the middle graph, Piers with high risk patients, sort of genetics, when you would actually say, well, actually, because what I found in your genetic workup, I would feel happier to have the maintenance type of treatment. So when you would kind of, well, I don't want to say put foot down, but where would suddenly become more important than everything else?
Yeah, that's a good question. So, I mean, increasingly patients are being, or we are profiling patients' disease more sophisticated than we used to. I mean, everyone should be getting P53 testing in whatever form that is, because that is actually required by NHS England before any doctor prescribes CLL medication in the UK, or no, certainly in England. I'm not sure that is general policy as well. But we also look at patients' immunoglobulin gene status, and that's the mutated versus unmutated. And we also sometimes look at more other molecular complexity, and increasingly, and again, should be available to all patients, you can have quite sophisticated genetic testing looking for mutations in other genes. And an example is something like the Notch1 gene or something like that. My view is that those patients who've got P53 abnormalities at any stage of treatment probably might benefit from longer term treatment than just finishing treatment after 1 or 2 years. There's some evidence to suggest, but it's not a direct comparison, that those patients do better on BTKIs than, so that would be ibrutinib or acalabrutinib, than for the fixed or the short term, let's say, venetoclax regimes. I think it is a bit of a generalization, but that would be probably one case where I would suggest to a patient that I think that going on longer term treatment with a BTKI might be in their interest.
Thanks, Piers. I think we've had some questions that sort of directly follow up. There's people asking if they reach undetectable MRD up to 12 months on acalabrutinib and obinutuzumab, is there any reason to continue maintenance on acalabrutinib? So I suppose we talked about ibrutinib mainly. I think this person's asking whether that sort of also relates to acalabrutinib, what you just said.
So, as I said at the beginning, we're only picking up undetectable, measurable residual disease in the bone marrow and blood compartment. So I don't know what's happening in the lymph nodes or the spleen. Probably that patient, I mean, I don't wish to suggest what treatment should or shouldn't be given. And the fact is, if you've received obinutuzumab with acalabrutinib, the advice, as the trial was that the acalabrutinib should continue. And we do not have any evidence, no data to say if we stop the acalabrutinib, what would happen to that disease. So it's a little bit, the answer is, I think that's probably a very good response, very encouraging. I think it would be a question of discussing that with the patient's doctor as to whether that's something the patient wants to do or not. I can't actually answer that question because we don't know the answer to it in terms of stopping. But probably one would suggest if there wasn't an MRD, if MRD was still there, you'd be more inclined to say carry on, would be my answer. I'm sorry to parry the answer. It's very difficult to comment on individual cases.
So I can try to answer some of the questions which are coming through. So is there anything in the pipeline? Yes. So in the pipeline currently going through NICE is venetoclax ibrutinib for both fit patients and frail patients. And actually that would very nicely sort out the high risk group patients. And I think, you know, this is where we're hoping to get approval for VI for that group. The other thing which obviously Piers mentioned, we don't have a data for maintenance type of treatment. There is a study, obviously static, which is actually looking at stop-start on ibrutinib. So those patients who are on flare, but it will also include patients who have got relapse, who are on a second and more line on ibrutinib. So this is something which we're learning from other leukemia, from CML, where obviously stop starting, you know, they've been using inhibitors since 2000, so they've got a bit of a 10-year head start than we do. But the maintenance treatment, from what we know now, probably won't be maintenance treatment in future. There will be some patients who will probably require to be on maintenance, but I think the patients who got good disease control, and I think it would be sort of preamble we had with UPS. So there are some patients you stopped. I certainly had two patients with PP53 abnormality. I stopped ibrutinib because of side effects. And I'm just waiting. They know that we can start acalabrutinib as soon as the white cell count are rising, but it's been almost 6 months now and they've been fine. So I don't know whether Piers you want to comment on that.
No, absolutely. I mean, I've stopped many patients on BTKIs, and it's been absolutely fine. So I mean, that's my point about clinical trial data versus what actually happens in the real world. And often we do collect real world data, and there will be collections around that going on. Of course, it's not actually a trial, whereas I think a trial is a good way of proving it. A couple of things I just come to in the questions, which are suddenly a lot. UMRD and MRD negative are the same thing. It's just undetectable measurable residual disease versus minimal residual disease negativity. So it's the same thing. Yes, we can go deeper than 1 in 1,000, but that's not what's normally reported in clinical trials. It's likely it will be genetic testing in the future rather than flow cytometry, which is a technical thing, but means it's more likely we'll go for even lower levels than we do today. And yes, you can get venetoclax in frontline. I think it's difficult for us to comment on patients' individual cases. I think we do have to, we can give some general advice, but it's difficult for us to comment exactly on your individual case, although I can understand why you're asking the questions.
And I think it's important just go, if you've got second thoughts, I would be very happy to, if you were my patient, just, ask for another consultation and go through your options and ask why.
Yeah, no, I agree with that. You're perfectly entitled to a second opinion. It's just, yeah.
Yeah, no, absolutely. Yeah, I think we can't really say, yeah, you are 49, you shouldn't be going on acalabrutinib. We can't say that. But I think what you can do, you can have a chat with your clinician and find out why it's, they decided that way, not the other. There was another question about acalabrutinib and ibrutinib. So if somebody progressed on ibrutinib, acalabrutinib is not an option. Acalabrutinib has got only place only for patients who are intolerant to ibrutinib, because they are very similar drugs. So if somebody progresses of ibrutinib, the chances are they will progress on acalabrutinib.
Thank you, both of you. I think we've covered quite a few questions there. Just to reiterate what we were saying about, some of you have asked, will I be able to have this, or can I do this? I think those are very, like Piers said, very difficult questions to answer in this setting. But if you do need any help working out who to ask and how to have those conversations with the doctor, we at Leukaemia Care can obviously point you in the right direction. But don't be afraid to ask these questions when you're sort of making the decisions. It's really important.
I can pick up Jeanette question maybe.
Yes. Somebody
who's had a venetoclax rituximab 15 months ago. So yeah, if you've got good remission on venetoclax, you could have that venetoclax again. It could be given as a venetoclax rituximab again, or venetoclax monotherapy. But obviously that would be or trying completely different drug. So that's the beauty of venetoclax being fixed duration, that you can have it second time around. And actually, when we look back sort of chemotherapy days, we did recycle old treatment. So if somebody responded to a certain type of chemo, so we're using the same things we learned from chemo days to the current treatment as well.
So I'll pick up on the question about immunity and treatment, and I think that's very interesting. We obviously all got very interested. Everyone's very interested in their immunity. I think some people were interested before COVID, but now everybody's fascinated by it, quite rightly. So using the example of COVID vaccine studies, and this is really just in how patients respond. And some of this is transferable to everything else. It appears that patients who've got a lot of disease, and that's generally patients who need to start treatment or about the time of treatment, but generally their vaccination response in terms of did they develop an antibody response was weaker than the normal population. And also true that for patients who received either a monoclonal antibody to CD20, particularly obinutuzumab, but also rituximab, or were on a BTKI, tend to not get or have a lower chance of developing antibodies to COVID vaccine, and that's probably true as well for other things as well. Off treatment, having had treatment some time ago and having been off treatment for some time, patients' immunity in terms of getting antibody responses seems to have restored to more near normal levels. Whereas those patients who are on long-term treatment such as BTKI may not be generating the best antibody response. So that's just one part of the immune system. And in fact, we've got a clinical study at the moment examining that question called IMPROVE. It's open at Birmingham, and it's open at King's, and it's open at other centres in the Midlands. And if anyone's interested in going on that, and they're on a BTKI and they were interested in that, there's various conditions. I'm very happy to be approached about that, because this is, we think, an important question. Is it safe to have a short interruption in BTKI to improve vaccine responses? So I think there is a conversation to be had about whether fixed duration, once you're off it and down the line, might be better for some aspects of your immune system. But you have to remember that measuring antibody response is only one part of the immune system, and there are lots of other things that go on, mainly T-cell responses as well. And we don't generally measure those in any form. We have some ideas about that. And I think it's important to remember that, you know, it's a very complicated situation. So I think high bulk disease and probably being on treatment, it just does generally mean your immunity is lower in those terms. I mean, Renata, you may have other things to add on that. I don't know.
No, I think you covered really well. I can't really add any more. But there is another question right at the beginning by Kay Berry about acalabrutinib obinutuzumab. So we were talking about undetected measurable disease in fixed duration. So actually with acalabrutinib obinutuzumab, there were some patients, it's rare to have not measurable disease. But the way this study been designed, so acalabrutinib is therefore given after as a maintenance. We don't tend to, so the clinical trial Elevate-TN been designed as a maintenance type of treatment, not as a fixed duration. And I think the investigators were surprised themselves that actually addition of obinutuzumab to acalabrutinib had such a good responses in comparison to acala. Obviously, we don't have a final data from this study, but so watch this space.
Okay, I think we've covered most of the questions up here. We've got 2 minutes, so very last chance anybody wants to ask a question. I spotted one that I don't think we've covered. So obviously we've talked about fixed duration treatment, so 1 or 2 years on therapy come off. We've talked about continuous, although there's some debate over whether that's the case. This person's asked about sort of intermittent treatment, they describe it as, so very short periods of time on treatment and a short period of time off treatment. And they're wondering if you have any views about that. Apologies if we've covered it already. I lost track a little bit about which ones we covered and which ones we didn't. But is there any work going on as to whether coming sort of on and off treatment intermittently, or is that not something that would be appropriate in CLL?
Do you want to take it, or shall I?
Well, I think a static trial is answering that in a way. The other trial that's actually also doing that is the flare study. So patients who are on flare, if they've, I mean, only one of the arms really reaches UMRD, which is the combination of ibrutinib and venetoclax. And if patients become negative after a period, they come off treatment. If they start, if that comes on again, then you go back on treatment. So that's very much directed by the results, rather than just saying, right, well, let's do it for a year, off for a year, on for a year. It might or might not work. I really do think something like that would have to be looked at in a study to really answer that question. And
of course, initially patient needs to be for at least 6 years on ibrutinib before we sort of think about stopping it. So it's not kind of early 3 months on, 3 months off. So
no, that would be very different doing it that way.
Yeah. There's a couple of things if I could pick up. So the question about maybe what I mentioned about acalabrutinib and venetoclax. Bottom line, you cannot say which one is better because there are no clinical trial. To actually say that one drug is better than the other, you need one clinical trial looking at those both arms, and there aren't any, and there are not any planned. So I think and we can't really we know what progression-free survival is for each clinical trial, and what we can say they're comparable. So that's why whether it's BCL2 inhibitors or BTK inhibitors, they are comparable. So that one, and then Loxo 305. So we are very excited about Loxo 305. There is a compassionate use for the patient. So because it's different BTK inhibitor, it will work on patients who essentially failed all the therapies. And it will work also on those patients who failed ibrutinib and acalabrutinib. But it's obviously there is no license at the moment, but we can use it on the basis of compassionate use.
I think your point about not comparing, not being able to always compare one drug to another, I think that sort of summarizes our whole discussion. You know, how do we compare between drugs and the amount of different things we should be thinking about, and how everybody sort of needs to look at it from their own individual perspective rather than sort of worrying about this fixed versus continuous. I think that's come across really clearly from both the presentations. I really appreciate both of your time, but we are already over time, so I had better wrap this to a close. Thank you both again. Really, really interesting. Some good feedback coming in already. I just want to very quickly, for everybody listening, cover everything else we do at Leukaemia Care in case you're not familiar with us. As well as these webinars, we have newsletters in our magazine, podcasts, social media, and our website with plenty of information on all of those. Specifically, our next webinar planned, although there may be one pop up in between now and then, because I appreciate December's a long way away, but the next one we have fixed in the diary is about employment rights. So if you are working and you have CLL, please do join us for that, and we will try and cover your questions. The last time we did this was during the furlough scheme, so I'm sure things will have changed ever so slightly there. Of course, plenty of booklets available if you need to read up more about CLL or its treatment. Next slide, please. And here's just a picture of our magazine and how you can subscribe to it if you'd like to. Our support services, particularly want to flag advocacy support. If you are really struggling to have that conversation and weigh up different options, I would really recommend reaching out to the advocacy team here. We're here to help you make sense of scientific data. We're here to help you approach those conversations with your doctor. We can't make the decision for you, but we can help you think through all the options. So please do reach out. Of course, we've got many other services there. Next slide, please. Just wanted to highlight a few support groups coming up in CLL. Those of you not yet on treatment, we do have a specific one for those on watch and wait or active monitoring as well. Next slide, please. Our body scheme, which can actually be really helpful making decisions around treatment. If you want to speak to someone who has already been through treatment, how do they weigh up one thing over the other? Please do reach out if you'd like a buddy to talk to about that. Next slide, please. I got ahead of myself. Here's the details of our advocacy caseworker that I mentioned earlier. Next slide, please. Our counselling fund. If you're looking for emotional support, we appreciate that CLL can be really challenging to live with day to day, and it's quite difficult to come by on the NHS counselling. So we do offer that ourselves. If you enjoyed today's webinar, obviously these do cost us to run, so we'd really appreciate if you could consider raising money for us. A simple way would be through our collection tins in your local shops. Or if you're looking for something a bit more adventurous, you could try our Run 50 challenge for the 50,000 people living with leukemia in the UK. And it's a nice one where you can choose your length. Or if you're looking really, really adventurous, feel free to cycle to Paris for us, which again, going back to my previous comment about exercise, that one's not for me, but I'm sure there are some fit people among you. Next slide, please. Let's finish this one. Finish with this one, ways you can get in touch with us while I say thank you again to Renata, to Piers, and to all of you for coming today, asking such great questions. Apologies for the technical trouble we had with the chat, but we got there in the end, and I think we covered all the questions you wanted to ask. So thank you, and we'll see you next time. Have a good evening, everyone.